Hello, Tina.
Oh, hello, Andrea. How are you?
All right, how are you?
Doing well. Are we the only ones here, or I
I
see
see
some?
I see LaShonda is up here.
Okay.
Yes.
And I
So
was
we
just so
have
nervous
one
about.
person so far.
Okay, good. And I just wanted to be able to be sure I upload my slides. Can I take a moment to do that? Is there a special?
Yeah, look down to the bottom where you see your camera, mic, and then you see a monitor with a line in it. That's how
Mhm.
you share
Then that goes to my. I see.
it.
Excellent. Do you mind if I just practice right here for a moment?
Yeah, sure. You can go ahead and have it up if you want it up.
Okay. I want to minimize user error because.
So how I'm going to do this is I'm going to introduce you.
Okay.
And then I'm gonna turn it over to you, and I'm gonna put my camera and mic on mute. However,
Okay.
I will monitor the chat bar box, in case, in case someone have any questions.
Okay.
So you had sent me an email saying you needed the link. Do you
Yes.
find it?
No, I'm good. I'm good. I was looking through that because I was remembering the training, and I'm like, oh no, it references here that I should be backstage somewhere, and I was like,
Oh, okay.
yeah, no, I'm sorry about that.
No, you're fine.
So, Andrew, where are you based?
I'm on the East Coast.
Uh
You know
huh.
where Nas Head at?
Oh yes.
Okay, so we're the last town that you get to before you get to Dare County.
Okay. I
Yes.
heard
Well, the
you guys.
town that has something in it.
Okay, yeah, where there's with the last town that's a town.
Yes.
I have a friend who's in Manteo, and she's just said that in Dare County, it's just the summer was so the traffic was extraordinary. Everyone was there.
It was. And see, they always come through our area and stop at our fast food restaurants and different stuff before, because it would be another hour and a half before they can stop again. So we get all that traffic. And then don't let a storm come. We get all that traffic when they try, and we have to open up the shelters and stuff because they normally will stop here.
So are you the last? You're the one far out though, not coming back.
No, coming
Closer to.
back towards Raleigh, that's us. Mm-hmm.
Okay, gotcha.
Mm-hmm. Yep, that is us. I'm in Washington County.
Yeah. Okay.
Mm-hmm. Been here all my life. I went to school and came back. Don't ask me
Oh,
why,
I.
but I came back.
That's good. It's good. I mean, I was born and bred in Chapel Hill, and when you find a good place, it's hard to, even if you
Mm-hmm.
go away, you come back.
Mm-hmm.
I'm so glad that you are instructing people to put their names and health departments. That's in creating this. I was just like, oh gosh, I don't even know where people what their
Mm-hmm.
HIPAA problems are. So it's good to have that context.
Yeah, and it's not a participant link, just like Zoom, where you can
Hmm.
look and see everybody.
Yeah.
It just tells me it's three people up here, so it's me
Yeah.
and you, and then one other person,
Yeah.
and that's all they tell me. Don't tell me the names or nothing unless they start typing in the chat box.
Hmm.
So, and then Kim said that they could get us the information on the participants, but it would be like next week sometime. So it's kind of good to know now while we're in the meeting.
Yeah.
Mm-hmm.
And I think you mentioned that maybe the ability to send out the
Uh-huh.
slide deck.
Yes.
Okay.
We're gonna actually Kim is gonna put the PowerPoints when I send them to her on the website.
Okay, good.
Mm-hmm. And that reminds me, LaShonda, I forgot to ask Dr. Sanders earlier about his presentation. I don't know if he wants to share it or not since it's research, but can you check on that for me, LaShonda, if you hear me? Thank you. And I have noticed I'm probably gonna get ready to take my camera down for a while until it's about time to start because people are not gonna come in
Okay.
until it's about time. So
Okay.
if you want to, if you got something to do, you can do that also.
Okay, thank you. Yes.
Good afternoon, everyone. We have a few more minutes and we'll begin. As you join the session, just add your name and the health department organization that you are representing. And we'll be back in a few minutes. Talking and my mic is not on. It's 3:15. I'm gonna give everyone a few more minutes to get in. I say probably about 3:18, 3:19. We'll get started. Okay. Good afternoon, everyone. We're gonna get started in about 2 more minutes. Okay, everyone, we welcome you to the new normal to HIPPA, Quality and Information Technology. Our speaker today is Ms. Tina Simpson from say that for me.
Atraumatus. It's a hard one.
Tina is a triple Tar Heel and received her Juris Doctorate from UNC School of Law and her Master's in Public Health from UNC Gillian School of Global Public Health, where she focused on delivering innovation and change management. As a compliant professional, Tina has proficiency in strategically aligning both legal and business risks. As an undergraduate, Tina majored in French, a background that has proved helpful as she frequently worked at the intersection of healthcare stakeholders, requiring frequent cross-sectional input and creativity. I welcome to you, Ms. Tina Simpson. Hello, Tina? Hey, you froze on me, Tina? She must be having some technical difficulties. We'll wait a few minutes and see if she can get back in.
Hi, can you hear me?
Yes, ma'am, I can.
Okay, good. I'm so sorry about all of that. Of course, it's the rule of the universe as soon as one's ready to go.
Mm-hmm. I know, exactly.
Well, I imagine we're ready to go now. Is all good? Okay.
All good.
All right, thank you. So I'm so glad to not see, but see the names of so many people here today. I know that HIPAA is not always a walk in the park, but I am thrilled to be with you today. I am going to take a moment to address that elephant in the room. Oh, well, no, first let me introduce myself. You know, as Andrea mentioned, I am a principal at Atraumatus LLC. Atraumatus is a small consulting firm, woman-owned. Atraumatus means fearless, and our tagline is that we do consulting fearlessly. I have 12 years experience in health law and regulatory compliance. This includes having served as chief compliance officer for a population health and data analytics company, and as an assistant attorney general with the North Carolina Department of Justice. As Andrea mentioned, I have a master's in public health, go Tar Heels, with a focus on change management and the adoption of care delivery innovations. I'm certified in healthcare privacy compliance from the Compliance Board. So this is the elephant that I wanted to start with. Not everyone feels great about HIPAA. So I want to ask, how do you really feel about it going into this? I would love it. I may not be able to see it because of the oddness of reading this, but if you could answer in the sections, you know, are you A, you love all things regulatory and this is going to be fun? And if so, you probably have a unicorn that you wrote here on. B, this could be useful. I'd like to learn more. C, this is something like the flu shot or a colonoscopy. It's just something that has to be endured and you will be stronger for it. You are a stoic warrior. Or D, all the king's horses and all the king's men dragged you here and you're actively looking for the exit. So I think probably in the context of like the bell curve of how people feel about regulations generally, but HIPAA in specific, it skews very, very far in one direction. I think that the idea of sometimes HIPAA training, HIPAA sessions are comparable to a colonoscopy. So I hope to make that a little bit less painful. My objectives here today are threefold, really. In addition to this introduction and giving sort of what I think is a thesis statement about why you should care about HIPAA and why HIPAA is more than just a privacy and security regulation framework. It's also a framework that, following recent regulatory updates, really is returning to its roots of trying to create a framework for greater interoperability across our very fragmented healthcare system. Before moving to this, providing you with a very thumbnail sketch of HIPAA in plain English. This is, thank you for your response there. I don't see any D's. That's excellent, because I know that there are days that I definitely am a D for when it comes to regulations. So in addition to these up to providing sort of a plain English approach to HIPAA. HIPAA is a term that comes up all the time in healthcare and public health. It's often misapplied and misconstrued. So it's good to start at the beginning and say what HIPAA is and what HIPAA is not. Then we're going to move to the updates to the regulatory framework that I referenced. And then go move to sort of the HIPAA risk assessment, because the HIPAA risk assessment is really a cornerstone, or should be a cornerstone, for your whole HIPAA compliance strategy. It is required as a covered entity or a business associate, and the failure to do one periodically, to update them regularly, and to be reflective and accurate in the performance of this risk assessment can place you at great risk. And really should be considered sort of the foundation stone and the thing that you have most control over, especially as we navigate a space that is increasingly chaotic. And then we have some time reserving to talk a little bit about HIPAA, COVID, and public health specifically. I'm particularly interested in learning a little bit more about what barriers you come up against in your practice as public health practitioners, and specifically whether you have those have been addressed during these particularly challenging times. So I'm an attorney, so I always want to start with the statute, to start with sort of like the literary preamble. And in this instance, I've given you some very flowery inspirational prose here. This is the preamble to the Public Health Law 104-191, also known as HIPAA. And it reads, "It is the purpose of this subtitle to improve Medicare and Medicaid program and the efficiency and effectiveness of the healthcare system by encouraging the development of a health information system through the establishment of standards and the acquirement for the electronic transmission of certain health information." There are two things that I really want to pull from this, and that is, from the very beginning, HIPAA interoperability was a cornerstone of HIPAA. It was a primary force for why the statute was passed in the first place. It was to encourage the adoption of electronic billing systems as it was then, and to encourage its proliferation, to make people comfortable with using it. So while privacy is central it creates an enforceable individual right, it was always privacy in pursuit of a larger goal. HIPAA is many things, but it also attempts to strike a balance between those individual privacy protections and the public interest. And it hasn't, that calculus hasn't had, for the past 24 years that HIPAA has been around in some form or another, that balance has usually tilted in the interests of protecting privacy interests. And that was an intentional decision, I believe, by a number of the legislatures who passed HIPAA. This is reflected by contemporaneous comments of Senator Sheldon Whitehouse at the time, who said, until people are comfortable with the security and with the exchange of their health data electronically, we need to err on the side of security and of privacy. I'm paraphrasing that slightly, but what I want to pull from that is that as important as privacy is, what privacy is also balanced against the public interest, and that public interest is, whether it's in the context here of a global pandemic as we respond to that, whether it is in the interest of a more efficient, less wasteful, more sustainable healthcare system, and quality of care. Those are, from the very beginning, those have always been part of that calculation. So with that sort of thesis statement on why HIPAA is not necessarily just a punitive, protectionary, defensive regulatory framework, but something that is perhaps a little bit more adaptive, I'm going to start with sort of my survey of HIPAA in plain English. It's hard sometimes to summarize HIPAA in a sentence or two, but I think this is my best attempt at it, which is HIPAA regulates the manner in which protected health information can be used and disclosed by covered entities and their business associates. It creates and enforces a baseline privacy right and right of access for patients. That right of access is often frequently overlooked. And its primary components, particularly as we as health or public health practitioners interact with HIPAA, usually fall into the 4 primary rules, and that is the privacy rule, and that is the creation of that actionable privacy individual right. The security rule, that creates a duty of covered entities and their business associates to actively protect the data. So not just to not disclose it, but to protect it from unintentional or intentional incursions. The breach notification rule, which requires notification to individuals and DHHS, and in some instances the media, where there has been a breach of protected health information that is likely to result in harm. And the enforcement rule, which is the very big stick. The Office of Civil Rights is the entity primarily responsible for enforcement of HIPAA, and it has the authority to impose significant civil penalties. So as we look at this, wanting to think about this in the context of the who, what, where, when, why, and this turns out to be a lot more who, what, and whens. So wanting to answer the question of who does HIPAA apply to? What data does HIPAA apply to? When is disclosure required? When is disclosure permitted? And what other duties are imposed by HIPAA? That's sort of the catch-all. So to address the first question, and there was an interesting exchange on Twitter that I'm pulling out here that I want to draw your attention to. The first question is, who does HIPAA apply to? We reference HIPAA a lot, but while it is a big statute, and if you do anything in healthcare, you are definitely impacted by HIPAA, it should be noted that HIPAA applies to covered entities and by extension, their business associates. Covered entities fall into 3 categories. These are health plans, broadly speaking, health plans, healthcare clearinghouses, and providers who transmit health information in electronic format, so all providers. HIPAA does not apply to the media. HIPAA does not apply to employers in their context as employers. And that is why I pulled out this tweet from circulated yesterday. It generated some interesting thread discussions. Former Press Secretary Sean Spicer took issue with, I think, NBC News relating the names of a new White House staffer who has tested positive for COVID, and Representative Donna Shalala, I hope I said that right, clapped back with "That's not how HIPAA works, and I should know, I wrote it." Donna Shalala was the Secretary of Health and Human Services in the early 2000s when the regulations first came out. The next question is, what data does HIPAA apply to? Because again, while HIPAA feels huge and all-encompassing, and it is all those things, it is still specific. So it helps in this context to think about the great universe of all the information that a covered entity or its business associate might have. HIPAA applies to a subset of that, very specifically to protected health information, and when it comes to the security rule, to a greater extent, the electronic protected health information. Protected health information is individually identifiable health information, which you see in that bigger square, that essentially doesn't have an exception to HIPAA. Some of those exceptions might be, including public health interactions and other things, or exempted research, or limited data lists. So again, HIPAA is still a subset of all information. The privacy rule creates an individually actionable right of privacy to your protected health information. And it mandates the ways in which covered entities and their business associates can use and disclose that information. It's important to distinguish between use and disclosure. They're often used interchangeably and at the same time, but they do mean two distinct things that can make a real impact, particularly when it comes to potential breaches. Use refers to internal use of that data. So however it's exchanged and utilized within an organization. Disclosure is anything outside of that entity, and that includes outside of that legal entity. So even if you're in a clinic, that is specific to the legal entity. You need to understand the distinction between mandatory and permissive disclosures. HIPAA is almost entirely permissive, and that is a quirk that we'll get to in some of the regulatory updates. But there are only two instances where HIPAA requires disclosure under HIPAA, and that is to the Secretary of DHHS for the purposes of compliance enforcement, and to the patient or his or her legal representative. Now, in use and disclosure, one of the most important concepts in HIPAA, the privacy rule, is the minimum use requirement. This requires the covered entities to make reasonable efforts to ensure that access to and use is restricted to a specific purpose, use, disclosure, or request. So it's as narrowly tailored as possible to what is actually needed. This protects extraneous information, so it protects the individual's privacy. It also protects the security by limiting the amount of information that is exchanged. In the absence of patient authorization, a covered entity may not use or disclose PHI unless it's pursuant to all of these things. And these listed things of treatment, payment, operations, compliance with the law, lawsuits, law enforcement, workers' compensation, et cetera, that covers a lot of territory. But again, it is still permissive. The ones that that are most generally used are, the first four: treatment, payment, operations, research. The security rule in HIPAA imposes a duty to actively protect and safeguard the data that a covered entity or its business associates maintain and transact. This is instead of just a sort of a duty not to do no harm by not improperly using or disclosing it. You are actively, liable for, potentially what third parties can do to your data when you do not adequately protect it. So this includes the requirement to implement policies and procedures to prevent, detect, contain, and correct security violations. And I'll note here, the mandatory periodic risk assessment is one of the first and indispensable steps towards compliance. The breach notification rule. This is what keeps compliance officers up at night. Covered entity, in addition to the significant penalties that we'll go over in the next slide, covered entities must promptly notify individuals who have been subject to a breach of unsecured PHI. Notification must also be made to the Secretary of Health and Human Services on an annual basis. And where the breach affects more than 500 individuals, That's not on an annual basis, that's promptly, and you also must notify regional media. So in addition to the significant civil penalties that HIPAA carries on HIPAA, there is the reputational harm, there's the expense of complying with breach notification. And to note that, especially in these days where everything is electronic, and where one of the biggest risks to the security of patient information is, cyber attacks, it is very, very, very easy to come up against that 500 tipping point in a single instance. Penalties. Penalties are cumulatively and potentially significant. The schedule of penalties range depending upon the intentionality, history, and impact of the individual instance and the history of the organization. So they go from anything as where it's just sort of someone didn't mean, it was an unintentional negligence on the part of the covered entity or the actor of the covered entity, to something as minimal as $100 an instance, to a lot more per instance. And additionally, in 2009, the HITECH Act expressly allowed for the state to levy additional penalties, including attorney's fees. This significantly raises the risk profile for non-compliance, as you can kind of get hit twice. Now, I wanted to use this space, having gone through that, jetted through the land of HIPAA in about 12 slides, wanted to take an opportunity to apply this practically and to get some feedback from you. I hope that it allows for that. I've listed some questions, but I'd like some feedback on what your biggest challenges that you experience with HIPAA are, how HIPAA compliance, if it helps or impedes your practice in public health. And this last one is a leading question, but how important access to individual data or aggregate community level data is to your practice. Is there anyone who might be willing to raise a hand and share their HIPAA experience, if we have that capacity?
I have to put it in the chat box.
Oh, okay. Okay. Thank you, Andrea. Well, I'll leave that then with you. And I think maybe sort of this space is as much to recognize that compliance with HIPAA can be burdensome, and it can certainly it can create a barrier between something that is sort of like the fuel for healthcare delivery and for public health delivery, and that's data. And so that leads to some of the unintended consequences. HIPAA is often cited as having a chilling effect on care delivery innovations, particularly as it relates to the exchange of data across providers and networks. This is in part because those disclosures are permissive. The exchange venues are fragmented, again, because of our fragmented healthcare delivery system. And the permissive nature of the HIPAA framework, combined with the perception of the very punitive stick without much of a direct carrot sometimes for the covered entity, can lead to a lack of incentive for sharing data outside of a given network or whatever their own covered entity's own locus of control. So I attribute this lack of data interoperability to a defensive, an understandable, rational, but misapplication of HIPAA regulations, and then lack of a market alignment and competing interests when it comes to interoperable access to data across competing stakeholders. Healthcare is a data-driven industry, and access to data is valuable. And that is just a restatement of that. I would refer to the health information exchanges as one example of this. Health information exchanges were one of, sort of a central repository where all stakeholders, regardless of affiliation, clinically integrated network, et cetera, could exchange and draw down information. This is one of the central goals of the HITECH Act. and it's central to sort of improving the quality of care and creating efficiencies. But despite the inherent opportunities, the acknowledged opportunities of this, HIE adoption has lagged. And various studies have identified access barriers, most frequently created by EHR vendors, as a frequently cited cause in that. There was one particular um, study done in 2017 evaluating reports of health information exchange executive directors across the nation, asking them to report on instances of information blocking, or and how it occurred, what was sort of the modality of it, who did it, was it an EHR vendor, was it a hospital or health system, and the most frequent culprit, EHR vendors. The most frequent barrier was the very high cost of connection fees. So very recently, we have the Cures Act, that partially was intended to address this. Here we've the access, use, and exchange of qualified electronic health records and other health information technology, business, technical, and organizational practices that materially discourage the access, exchange, or use of electronic health information where the actor knows or should know it's likely to impede that. The Cures Act defines sort of the elephant that has been in the room and that people have been talking about, 10 years before, and that is information or data blocking. It defined it and it prohibited it, and it directed DHHS, specifically through the Office of the National Coordinator for Health Information Technology and CMS, to develop a regulatory framework to enable a truly interoperable system. And that is the word of the day: interoperability. I've included here sort of a definition from the Interoperability Working Group, which defines it as the characteristic of a product or system whose interfaces are completely understood to work with other products or systems, present or future, in either implementation or access without any restrictions. Interoperability is started as an IT term, as an engineering term, but in no small part because of how dependent healthcare systems are upon IT framework and technology and that exchange. It is now applied to systems in general, and it is truly one of the big goals in our transition towards value-based care, health reform, and towards population health as opposed to just individual clinical interventions. So that brings to the regulatory updates. The Cures Act, as I stated, defined data blocking and said, okay, we've got to do something about this, build a regulatory framework for identifying when this happens beyond you know it when you see it, and create consequences for actors that engage in this. And before zooming in on the regulatory framework itself, I want to again underscore how important access to data is, interoperability is, the reduction of that friction or uncertainty between, appropriate entities to disclose patient information. And this comes from CMS Administrator Seema Varma, her address to HIMSS last year. She said, technology and the sharing of data underpin the entire move to innovative payment mechanisms in healthcare. Without effective, open data sharing, providers cannot keep patients healthy. Without data to track patient progress or understand quality, payers cannot tie payment to outcome. So interoperability and the exchange of data is central to all of the big plans we have for improving healthcare. Now to zoom in on the regulatory framework itself. The ONC's final rule in interoperability and patient access was implemented in March of this year. And despite the fact that this was the culmination of truly decades of or at least a decade of work of, state industry stakeholders, including EHR vendors and health systems providers, engineers, talking about what are the standards that we need to operate by and what are the barriers that we need to address. The promulgation of this final rule was still very controversial in some quarters, and that is because it truly does upend a business strategy of some very powerful stakeholders, and it is a very big change. So I would note specifically to, I guess, back in February, the Epic and some other EHR vendors, among some of the larger health systems, started a campaign to revise the implementation timeline and this projected final rule, and citing valid concerns that we'll turn to in a moment. But at the same time, what I do want to stress is the final rule, it wasn't something that just sort of came up after the Cures Act. This has been a progression, and as in all things, it's sort of been, everything's been sort of hammered out well in advance and reflected, I think, a very broad consensus. So again, this rule defines information blocking. It's hard to define, so they define what it isn't. They give 7 or 8 examples of don't do information blocking, but here are some sort of, unless it's these things, if you can fit it into these essential safe harbors, you're kind of at risk of being called information blocking, and the onus is on you, health system or EHR vendor primarily, to justify that. It moves from the more limited common clinical data set to what is called the U.S. Core Data for Interoperability Standard. This is perhaps one of the most significant practical applications of the rule. The common clinical data set, sort of requires sort of this truncated data set to be transferred between providers, but it lacks the regularity and the granularity to be useful in the context of actual patient interactions, point of touches. The USDI standard includes all case notes, so effectively it's requiring access to the complete record. And then it provides sort of health IT certification criteria, which is a prerequisite for participating in Medicare Medicaid, to vendors and to EHR vendors. And this specifically is requiring them to create, over the course of the next 2 years, create and implement an API standard. Okay. Can you hear me? I tried muting. Okay. So the API standards, which is the intersection between, which is essentially just a vector that allows allows you to extract data from, an Epic, from whatever the EHR system is, and utilize it, and pull it and put it somewhere else without having to be in Epic. And there's a very detailed framework that we'll look at in terms of sort of the timeline for doing this, and the penalties for failure. And that's where we are. So it too, as I mentioned, sort of the framework for these interoperability rules were very, this is a long time in coming. There's a lot of insight that have gone into this. This is the product of the work of the FIRE Argonaut research group going back over 10 years. And as a consequence of that, we've got a 2-year timeline for implementation. This is, I think, both very feasible, but it's also still quite aggressive, because you are talking about really requiring third-party vendors, software app developers who want access to data, and to work with the EHR vendors to create APIs to extract data, educate patients on how they can give permission for the disclosure of this data, and then start penalizing for failure to do that. So I think one thing that I think I've neglected to sort of touch on here is at the center of this is sort of patients' right to direct data. Data is, if you've had this experience as yourself as a patient, or when advocating for a patient, it's not a seamless process just to get your own data, just to get your own medical records. The intention here is to make it sort of a bias towards sharing, and to make it so that a patient can direct in a systematic way for the disclosure of data to third parties, software app developers, mHealth, digital health, and to allow for that data to go there without having to check the box every 500 times. So we're, as you can see from this compliance timeline, so that's a big task. That's a big technological task. That's a big administrative task. It requires a lot of notice and coordination, and we have deadlines that come up this year. So this year, the EHRs need to demonstrate a deadline for real-time testing implementation. In less than a year, in April 2020, is the first attestation that they are meeting these requirements. And within less than 2 years, as of now, actors, so hospitals, health systems, EHR vendors, providers, to a lesser extent, can be penalized for failing to meet these standards, or excluded essentially from as Medicare, Medicaid vendors. CMS has a complementary final rule on interoperability and patient access. It's a little simpler because they have a slightly less purview into this. They are requiring hospitals to notify other providers of patient ADT events on a routine basis. This is probably, I think, one of the biggest components of the CMS rule itself, and I'm sure one that many providers will cheer. The idea being that if your primary healthcare provider is not within the network of the hospitals that it goes to, or the health system it goes to, all of his providers should be able to have insight into what's the care of that patient. So it creates a bias that unless the patient has directed that this data should not be directed in this way, that there's a sort of a bias towards disclosure, towards appropriate disclosure. Similarly, health plans will be required to create those same sort of APIs in order to allow for the exchange of data to third parties at patient's direction. And it requires sort of a mandatory updates to notice of privacy practice and communication with patients. Now, there are legitimate, real concerns that come with these very big changes. The first and foremost is privacy protection. Opponents to this regulatory framework have rightly cited that this can essentially work as a backdoor to just sort of declassifying protected health information, and that patients either lack the time, the interest, the ability to make informed decisions, or to recognize that they're losing data protection when they allow a third party, such as a Google, or the smart health phone app on your phone, or whatever other software developer that you allow to access your data, that essentially removes it from the HIPAA protections. There are legitimate concerns as to the transparency of these other third parties in terms of being transparent with their own privacy practices. And there are concerns with the enforcement timeline, and sort of, I see this one less so, but sort of the fairness of the vendors have developed this strategic bulwark, and it's unfair to deprive them of the benefits of their investment. I personally think that those rewards have been reaped. But to point to the privacy and transparency concerns, these are real, and I know for myself, I don't always read. I don't read the updates to terms of service on my iPhone all the time. So similarly, the idea of you know, making it so that a patient can click a button and allow his data to be moved to someone who's no longer covered by HIPAA, that data is just out there, is concerning. It's also concerning. I've taken a few digs here at sort of like the industry power players when it comes to data. The vendors and health systems. But I don't know that Apple or Google are necessarily who have each been making sustained plays into the market are necessarily they're no small fries either. So these are real concerns. I think that they are addressable concerns. I also think that this is also part of a larger discussion that we have in healthcare and in public health, of moving from a very hierarchical structure of interacting with patients, and where the provider is here, the patient is here, and that asymmetry. If we really mean that the patient is supposed to be controlling his access to data, his care, then we need to make a system that honors those the disposition of that data. With that said, that does mean it does depend upon transparency and holding, continuing to regulate the manner in which to ensure that those are informed and enforceable authorizations. So I'm going to switch gears a little bit now to move from sort of updates in the regulatory world to looking forward and the security risk assessment. And before I do that, I'd like to ask if anyone has any questions, because there was a lot of information in that. If you want to type any questions as they relate to the regulatory framework, this might be a good time for that before we move to this next part. Okay, I'll take that as that it was very clear. So looking forward, moving to the security risk assessment. I'm sure that all of you have had to do this, have interacted with this, and it's not always fun, but it is incredibly important. So I'm going to make my case for why this is increasingly important. And that is, the reality is that we are working in an increasingly complex and interdependent digital world. Data breaches by cyber attacks are so common that they sometimes seem to be mundane. To illustrate that, there's one, I look back at 2019 alone, 38 million electronic health records were breached. This was a 20% increase just from the year before. While ransomware through phishing is certainly the most common culprit, we should not fall prey to the tendency to just sort of focus everything on that, because we cannot underestimate good old human error. And that includes the operational workarounds workforce members employ to shortcut what may be perceived as the burdensome barriers to workflow. So, we need to take a holistic approach when we think of our EPHI risk profile. The risk, when I say that the risk assessment is of increasing importance, it's not just because of the increase in risks facing an organization, or increase of threats rather, and the difficulty in anticipating and preparing for all of them. It's also reflective of the increased importance regulators have placed on both organizational and security risk assessments. This is reflective of the fact that regulators recognize the complexity and the diversity of the organizations that are subject to HIPAA and other compliance frameworks. And while the security risk frame, so it's important that they've taken increased importance. So it's not just to detect, but it's also to document your good faith compliance, to identify and to address them. So it's not enough to just not have any breach incidences. You really need to show that your compliance program is effective, and you really can't do that if you don't take inventory at the beginning and have a plan and document, if you don't measure it. This is reflective of a general evolution in corporate compliance. This year, the DOJ updated their 2020 guidance on corporate compliance programs, and there is an increased focus not only on not just pointing to a policy that you have it, but being able to demonstrate that it is effective, that it is adequate, that it is tailored to your needs. Because the onus is increasingly on the organizations to demonstrate that the adequacy of the measures that were in place should something happen. This is also reflective of OCR's preferred governance approach. It views itself as both an enforcement agency, but also a technical advisory resource. So for a lot of, particularly the first-time offenders, or first time where there's an incident or reportable incident and they're working with someone, they really look at sort of the corrective action plan and creating sort of the resources to get an organization to where it needs to be. And the risk assessment is the starting point for that. This is reflected in some cold hard data as well. If you look at recent OCR enforcement actions, the failure to conduct a risk assessment is invariably features. I think that over the last 2 years, I can think of only one where that wasn't a component. And in the most serious cases, this is a big component for why they will argue that an organization was not just negligent or this was a mistake, but that this was a persistent, habitual pattern of reckless disregard for the security confidentiality, integrity of the data in their use. So there are 4 components to a HIPAA security management process. These are risk analysis, risk management, a sanction policy, and information system activity review. As you'll notice, risk analysis is the first required step in complying with security rule. And this risk analysis has to include assessment of the administrative, physical, and technical safeguards. Risk management is then what you take away from that risk analysis. How are you going to manage the risks you identify? The sanction policy is demonstrating that you mean business, that you are going to enforce the policies that you have in place as part of your risk management structure. And then the final status is that sort of information system activity review. That is auditing and monitoring. It is, again, not enough just to point to a policy. You have to actively monitor, log, iterate. Your compliance program can't just be a black box and you hope nothing comes out. You have to be proactive. So what is in a risk assessment? It accurately inventories the data exchange pathways, and technology assets of your organization. It will reflect an accurate understanding and evaluation of the operational processes that intersect with or depend upon these assets. It identifies the vulnerabilities present within these processes and assets. It identifies the opportunities that exist for actors to intentionally or unintentionally exploit those vulnerabilities. And it estimates the likelihood and impact severity that would result from such a breach. That's sort of the basics. But to go a little more granular, what are the components of a very effective risk assessment? An effective risk assessment will identify both general zones of risks as well as specific vulnerabilities. This is important because you need to be able to identify sort of where to pay your attention, but then you also need to have specific vulnerabilities so that you can have actionable steps to take. Insofar as possible, it quantifies risks. This is actually required under the security rule, and this evaluation has to integrate both likelihood and impact and the severity of a projected impact if that did happen. This is important because it helps establish operational priority. We are all working with limited resources, and you need to know where you get the most bang for the buck, or where you really cannot have a fail. It also forces stakeholders engaged in the assessment process to think with more precision. An effective risk assessment essentially provides a plan to identify risks, to capture noncompliance, and to mitigate impact. This is your framework for operations. It should be the foundation for your annual compliance plan. And finally, an effective risk assessment integrates diverse stakeholders, and this includes organizational leadership and board governance. So in conducting a risk assessment, the first step is always developing your framework. I have a picture, whenever I think of stepping into conducting an annual risk assessment, it can be overwhelming. And my mind goes to the family circus, as we have Billy here, and he goes his trek throughout the world, not a straight line. And when you're working with something that is expansive and big and important, it is very easy, if you don't start out with a plan, to start rabbit holing, to get distracted, to put it aside, to come back to it. It's important to have a methodology. It's important to have discipline from this outset. For that reason, start with a framework. And this means that your risk assessment needs to follow not only an established repeatable methodology, and I specifically recommend the SRA tool that's available online, but also to have a risk assessment plan, implementation plan for the timeline for when you're going to conduct this. What is the scope of it? Who are the people that are going to be participating in it? Project this out as early as possible, because it's always going to take long, or at least for me, it always ends up taking longer. And you need to be able to measure your progress against that. Defining the scope of your framework is the first step. Identify the domains. If it's restricted to a security risk assessment alone, at a minimum, this needs to touch on the administrative, technical, and physical safeguards as they relate to the protection of ePHI. Again, the ONC and OCR have an interactive security risk assessment that's available online. This is an excellent resource, and it is designed specifically for the small to mid-sized entities who particularly don't have the resources to invest in an annual third-party risk assessment that is more typical for the larger covered entities, or have a whole compliance office at their disposal. This is what I want to say, though, one caution in using this is that this is a starting place. And while it is intended specifically to be as simple as possible, this is still hundreds and hundreds and hundreds of pages of questions. And while it can be completed, and it's not necessarily particularly onerous to complete if you're just checking boxes. It's intended to ask the questions that get the discussion going, that force you to think about your individual situation. So just completing the SRA tool online as a cursory and solitary experience is really not adequate. Just a moment to talk about sort of the scoring methodology. As referenced earlier, this has to include the likelihood versus severity of impact. This is pulled from. This is one that's frequently used, sort of the high, low, medium. The benefit of this is its simplicity and its visualization. This can be very useful, particularly with when you're presenting something to leadership or to the board. Your eyes are naturally drawn to those red. It gets your attention. I will say it's sometimes difficult because sometimes it's subjective, it can be subjective. So this is also why it's important when you're evaluating likelihood and severity of impact that this is not a determination that's made just by the compliance officer or just by the key stakeholder. This should be a discussion. It should be validated against across people because of the interrelation. So I've created for you sort of a checklist for creating and executing on a risk assessment. As a reminder, you want to define the scope of the risk assessment, identify existing data sources that will drive this assessment, identify stakeholders, and this includes leadership, to champion the risk assessment and its subsequent implementation of how to address things. Also identify stakeholders with key knowledge who need to participate in the risk assessment. Start with an implementation plan and timeline and hold yourself to it insofar as possible. Determine a scoring methodology. Conduct the assessment, do the things. And in doing the things, iterate upon it. Consider validating against stakeholders. This should not be done in isolation because the risk, your organization's risk profile is not concentrated in one area. It is interrelated. And then after that validation, evaluation, prioritize the risk and complete the report. Sort of a pro tip, visualization keys are very important for engaging leadership and board of governance in particular. There is always an element of training involved in this, and it's much easier if you can graphically represent something such as that sort of hot level, green light, red light, yellow light. Now, as I've probably said 500 times already, having conducted the risk assessment, that's not all. What you do with your assessment is just as important. The risk assessment is intended to be an iterative, integrative activity. You can't just identify a risk and not address it. You can't just address a risk in a discrete moment. It is something that is going to continue as a vulnerability or a threat. It's going to have to be revisited. You're going to have to monitor it. So I would urge you to think of the risk assessment as the foundation for your organization's compliance plan. While HIPAA compliance is kind of the foundation of a lot of our compliance programs in health, it really extends to more than that, your risk profile. And this is an important opportunity to perhaps to build up your compliance efforts across an organization. So when you're working on this, consider how you'll share this risk assessment within and across the organization. What are the plans to address those risks? What resources are needed to fulfill your plan for addressing those risks? How will progress be tracked? And how will you know when the assessment needs to be updated or revisited? Now, the first questions on this all sort of tie back to this is why it's so important to integrate leadership, to integrate champions within management and leadership, and to educate the board of directors or governance related to this. I think I've hit that probably a little too hard, but so I want to revisit, how do you know when you need to update or revisit your risk assessment? Well, the risk assessment is, HIPAA only requires that it be periodic. I very strongly recommend that this be an activity that you engage in at least annually. And the reality is that part of this is part of an effort to systematize operations, and the chances are that, as you will see here, one of these triggering events are likely to happen within a year. You should update your risk assessment at minimum whenever there's a change in systems, strategy, economic conditions and resources, your service business lines, or what are you doing, how are you doing it, updating regulations, enforcement trends, or a substantive change in workforce or training needs for workforce. So again, it's not mandated that it be done annually, but I think that it's so much of this is important to systematize it because, again, compliance too frequently can get backburnered until there is the oh shoot moment. So to return to I think some parting wisdom on risk assessment is an exercise in program evaluation. As public health practitioners, it might be easiest to think of, and this is how I think of it, a risk assessment is a program evaluation. How are you doing in compliance? It's also an exercise in diplomacy because program evaluations require diplomacy. You need to be diplomatic, persistent, but diplomatic, particularly because you're scrutinizing your not just yourself, but how other people operate within the organization. So diplomacy is an important attribute. It is an exercise in board governance and management. It's an exercise in documentation. This is an important exercise in terms of the outputs that it forces you to engage in, but it also is an exercise for documenting that you are doing these things. This is your exhibit A, exhibit B, C, D, to demonstrate your good faith efforts to take all measures needed to reasonably anticipate these issues. It's an exercise in investigation and rabbit holes, strategic planning, and did I mention diplomacy? Now, we have, I think, maybe 10 minutes left. I've spent this time updating updating you on sort of the changes in the regulatory framework, and then sort of these planned, progression of the increased importance on, your own internal ability to develop your own plan for complying with HIPAA, because, in no small part, because it is not something that can be mandated effectively by OCR. One size does not fit all, and you need to be proactive. But of course, this past year has been an interruption of scheduled programming. HIPAA, COVID, and public health. You can't speak about health today without acknowledging that we are in the middle of a global pandemic. There have been regulatory changes, or rather waivers or relaxations in enforcement that have come out of OCR and DHHS in response to COVID, that extend to, sort of lack of enforcement for good, where there's a good faith effort in relying on the privacy rule, as it relates to telehealth, for example. I also think that it has been an opportunity to demonstrate how important access to data is, how important public health activities are, how important the infrastructure that public health authorities work within are. We, even within public health, which we have some of the best, sort of great reporting databases, the CDC is a wonderful resource, but I'm still astonished by the degree of fragmentation, duplication, and kind of administrative burden that is associated with, the various different databases related to specific disease profiles. There is a lot of improvement that needs to be made in order to have a more perfect interoperable union. So that is, I want to throw that in the context of, as we go into sort of a very brief question session, so that you can ask questions about public health issues with HIPAA. But I wanted to just briefly summarize sort of the conclusions that I hope you can draw from this presentation. From the very beginning, the benefit, quality improvement, and cost efficiencies were at the center of, and the impetus for HIPAA. These recent regulatory actions return to this intended focus. So when I say that the ONC's final rules are revolutionary in HIPAA, I mean revolutionary in the context of that it kind of takes us full circle back to what is the public good that we are seeking to correct and to course navigationally correct here. In an increasingly complex digital care delivery world, the risk assessment is an indispensable, integrative, and iterative activity, and instituting an effective framework to protect the confidentiality and integrity of data provides you with the greatest amount of control in this chaotic world, and enabling you to navigate that effectively. And then finally, public health practitioners are play an indispensable role in leading the transition to more effective efficient, and equitable delivery of health services across populations. Public health truly functions in this age as the chief strategy officers for health in a community. So understanding the objectives and parameters of HIPAA is an important tool to empower that mission so that as public health champions, HIPAA can be a start of a conversation for how you do something, how you stage an intervention or partner with a community-based program to serve the social determinant needs in your organization, in your community. So HIPAA starts that conversation instead of just ending it. It's important. Information is power, and I hope that this presentation has provided you with a little bit more power going into your important work.
Okay. Do we have any questions?
Oh, and I have muted you, Andrea. I am sorry. Let me try that again.
Okay. We don't have any questions. Okay, seeing none, we would like to thank Ms. Tina for her presentation today, and we will stay online for a few more minutes just in case anyone have any questions. Thank you.
Thank you all.
Yes, I apologize for that. I didn't mute myself after I told you that they had to put the information in the chat. I'm sorry. But I'm glad you did. Actually, my health director was on it, and he got somebody to walk around here to tell me I wasn't. Wow. Okay.
Oh, thank you, Wes.
Well, I really enjoyed your presentation. I'm actually the HIPAA compliant officer here at our agency, and we are really trying to get ourselves back on track. We are now with Logically as our IT person, and they did our last risk assessment. So hopefully we're going to get all back in compliance and have all our policies up to date very soon.
Yeah, it's congratulations. I know that it's wonderful when you're able to like, okay, got this.
Exactly.
We can go from here. Oh, wonderful. Yes, Monica, I'd be happy to, I'm just going to type, it's Tina at atraumatisconsulting.com. So then that's.
And I'm also going to get Tina's PowerPoint and send it to Kim so she can post it on the FAMI session.
Yes, and please reach out. There are some resources that I'd recommend. The National Institute for Public Health Law is also a wonderful resource, and they've really they've put together some great frequently asked questions on COVID as it relates specifically to health departments. So please do reach out to me, and I will shoot you my my e-copy of that because I've certainly referenced.
Perfect. Thank you.
Thank you all. It was good seeing you in the chat.
Thank you. Bye.
Bye.